You're watching Baptist Health's Resource Live, where our respected experts bring you timely and practical health and wellness information to improve your family's way of life. We're healthcare that cares. This is Resource Live.
Hello, everyone. I'm journalist Neki Mohan, coming to you live from the Baptist Health newsroom. There isn't a one-size-fits-all approach in terms of treating breast cancer. Each patient is assessed by a team of doctors, and together they will all make the decision of what treatment plan fits best. We have with us three experts from the Baptist Health family joining us to talk about finding the best treatment plan for you. I'd like to welcome Dr. Victor Guardiola, breast cancer oncologist at the Miami Cancer Institute. Thank you for being here, doctor. And Dr. Jessika Contreras, radiation oncologist at Miami Cancer Institute. Happy to have you too. And Dr. Kerry-Ann McDonald Breast Surgeon at Lynn Cancer Institute. It is a pleasure to have you all with us today. Before we dive into today's subject, I want to remind everyone that this is your discussion. Viewers, send in your questions and comments throughout the segment. We are here for you, and we're happy to answer any questions you may have. Let's get right to it. We're going to start off with Dr. Guardiola. Doctors consider many factors when deciding what is the best course of treatment once someone is diagnosed with breast cancer. Can you walk me through how treatment plans are determined?
Yes, of course. Thank you for the invitation. And to start off, obviously, as you know, the diagnosis of breast cancer starts with a biopsy. And that biopsy is the starting point of all the information that we certainly need to start some of the planning. So besides the people that treat breast cancer, like the physicians that are here with me today, we depend also on radiologists and pathologists to guide us into being able to subclassify and subtypify the breast and know the extent of where the breast cancer might be at. Once we start there, we subclassify it and we know the extent, then depending on all those variables put together, we approach the case in a multidisciplinary way where breast surgeons, medical oncologists, radiation oncologists get together and design the best course of action for that individual and unique patient. And although breast cancer as a whole is one entity, there's certainly uniqueness to each case. So it's important to have a multidisciplinary approach where medical oncologists that deal with medications, radiation oncologists that use radiation therapy, and certainly breast surgeons to take the tumor out of their bodies is the right way to go. Yeah.
Excellent. And now to Dr. Contreras, you know, when someone says breast cancer therapy, everybody thinks chemotherapy. I have to have chemotherapy. When is chemotherapy used as a patient's treatment plan?
Sure. No, that's a great question. Thank you for having me. Like Dr. Guardiola mentioned, there's so many factors that we really take into account, and it's that multidisciplinary approach that makes a difference for a patient. When we think about chemotherapy, usually we think about chemotherapy for patients that have a large primary tumor, that either have lymph nodes that are involved with cancer at the time of diagnosis. Aside from just how big the tumor is or whether lymph nodes are involved, we also look at other factors like different characteristics that the breast cancer itself may express. So patients that have triple negative disease or patients that are HER2 positive. So those are patients that we usually think about chemotherapy. Now, there are tests that we can run in patients that have early stage breast cancer after surgery that helps us determine what the risk may be of cancer coming back somewhere else in the body. And we use those tests to help us guide whether or not we'd recommend chemotherapy for those patients.
Thank you, Dr. Contreras. We went from diagnosis to course of treatment. Now we're going to the surgeon. Dr. McDonald, surgical procedures can seem very intimidating to some patients, but learning about the options that they have can help ease their mind. What is the difference between a mastectomy and a lumpectomy? And do all patients qualify for these procedures?
Sure, thank you. So a mastectomy essentially means that you're removing the entirety of the breast. There are different kinds of mastectomy, depending on where the cancer is and what the patient desires. The lumpectomy is removal of the lump. So you still have your breast tissue, but you're removing the lump. So, you know, it's important to know that the survival between a lumpectomy and a mastectomy for patients is equivalent. So there's no difference. So the way that we make those surgical decisions depends upon how big the tumor is in relationship to the woman's breast size, whether or not this is a unifocal cancer, meaning one spot, or if it's multiple spots in the breast. Genetic testing sometimes plays a role in that decision-making. And unlike a lot of other subspecialties, the patient also has a choice in what they want to do. So, there's a lot to consider before we make that decision.
Yes. No, great advice. Dr. Contreras, some forms of breast cancer are affected by hormones like estrogen and progesterone, and those have their own treatment method. How does hormone therapy work?
Sure. So breast cancer is unique in that it can actually express different receptors at its surface. And some of these receptors are receptors that respond to the hormones that are naturally occurring in our body, like estrogen and progesterone. So these medications take that into account and essentially work to decrease the amount of estrogen in our body or help provide a directly block essentially the receptor so that the estrogen or progesterone can't directly attach to that receptor in the cell. And so these hormones normally make breast cancer grow. So by blocking the receptor, decreasing the amount of hormone in the body, we're essentially treating the cancer by not allowing it to grow, by blocking that sign that's telling it to grow.
Awesome. And also, can radiation therapy is another form of treatment for breast cancer patients? When is it better for a patient to receive radiation rather than chemotherapy? And what are the different types of radiation therapy, Dr. Contreras?
Yeah, that's a great question. So when we think about radiation therapy and breast cancer, I don't think it's an either or question with chemotherapy. It's more about the specific patient. So like Dr. McDonald earlier explained, some patients undergo lumpectomy. So in women that undergo lumpectomy, you know that radiation has been shown time and time again to decrease the risk of breast cancer coming back in the breast itself. And for every 4 women where we prevent a recurrence, we are also saving a life. So radiation therapy is a very important part of treatment for women with early stage breast cancer. In women that have more advanced disease, so whether that's a bigger tumor or whether that means that they have lymph nodes that are involved, we know that radiation therapy offers similar benefits. In those women, we may be treating a larger area like the breast and the lymph nodes, whereas in someone that has an early stage breast cancer, we may only need to treat a small portion of the breast or the whole breast itself. Now, there are many different types of radiation therapy. The conventional radiation therapy that people usually think of is photon treatment or X-ray based therapy. We also at Miami Cancer Institute have more advanced radiation therapy techniques like proton therapy. And these are just different types of radiation that have different characteristics and help us reduce either dose to different parts of the body, but ultimately help us provide patients with the same oncological outcome.
Awesome. Dr. Guardiola, looking at your family's history is really essential after you've been diagnosed with breast cancer. But what about treatment? Should patients consider their family history of breast cancer before making a decision regarding their treatment?
Yes, for sure. Patients should consider that, and we will remind them. It's important to gather not only the personal history, but the family history as well, because that can elucidate some potential genetic predisposition to certain malignancies, and not necessarily breast cancer altogether, but sometimes we find like a common denominator that can place a patient at risk for future development of a cancer that has nothing to do with breast. So the family history, along with, in some cases, specific genetic testing, leads to not only a change in how we approach that particular case, but how can we end up approaching the whole family, and as well as prevention for future problems for that particular patient outside of the diagnosis of breast cancer. So it is important for the patients to be aware of their family history if it is possible, right? Adoption and some other, obviously, situations can make that difficulty, but overall, we need that information is important, absolutely.
Yeah, I mean, and talking about it too, because for a long time, nobody talked about cancer in families. Dr. McDonald, some treatment methods are used together to create the best outcome for the patient. After surgery, do patients need to undergo radiation therapy or chemotherapy? And how is that determined? I think Dr. Contreras walked us through that. But again, it's with a team like we have here, that you guys make those decisions.
Exactly. It's definitely made with a team. Surgery offers great local control of cancer, meaning we're removing the lump or whatever, the mass that the patient can feel. But I'll say that it often takes more than surgery to decrease one's risk of recurrence, and surgery is usually not enough. So we combine that with the other therapies that we've been talking about, radiation and chemotherapy, for example. So in general, patients who undergo lumpectomy should have radiation to decrease the risk of recurrence, because there's still breast tissue and you want to kill any microscopic disease in and around where the tumor was. Patients who undergo mastectomy in general do not need radiation. There are caveats to that. And so it's made on an individualized basis. And there's even changes now in how we treat elderly patients with breast cancer and whether or not they undergo some of the same therapies. So definitely not one size fits all.
Yeah. And then with that said, Dr. Guardiola, we know cancer treatments can be really hard on the body. What are some of the general risks and side effects for chemotherapy and radiation therapy? And is there any way for patients to reduce these side effects?
Yeah, great question. And I think pretty much the question that led patients to fear the most after being diagnosed with the condition is, what is my fate as far as side effects and my quality of life and all that? So a simple rule tells us that obviously whenever we weigh in treatments appropriate for breast cancer, we're always weighing in not only the pros, but the cons. So we know there's collateral consequences on the treatment, but we have measured that to the extent of knowing pretty much the boundaries of how much we can push certain therapies, at least for chemotherapy and anti-hormonal therapy and the medications that pretty much a medical oncologist use. There's always a balance in between them too. And to the extent that we have certain medications that are excellent cancer killers, but they will never be able to be used because of the side effect nature of it. So for the most part, that balance will lead to certain side effects, but they're all manageable. I used to train many years ago when the supportive medications, we call supportive medications, any intervention or medications actually that are there to actually deal with side effects, were not as good as nowadays. So the chemotherapy pretty much was the same, but the supportive medications were not there. It still was doable, but it was a difficult journey. Nowadays, I wouldn't say it's a walk in the park, but the side effects are manageable. Certain nausea, certain feeling fatigue. The hair loss that we can talk later a little more in detail. We have some things that we can try for that, but the hair will, for the most part, grow back and whatnot. So we always keep in mind the balance of them too in decision making, no question. Certainly not favoring lowering efficacy, but for sure a balance in between them too. And I let Dr. Contreras to comment on radiation.
And I think, from a radiation perspective, it's a similar story. Our side effects were much more pronounced and intense several years ago. Our techniques have improved dramatically. Our treatments used to be 30 treatment days. Now we can treat patients in as little as 5 to 16 days. And all of this knowledge has essentially led to better quality of life outcomes for patients and reduced toxicity. So when I talk to my patients about radiation therapy, if they are receiving only whole breast radiation, the most common side effects that they will experience is fatigue. So a lot of women will say that they feel tired during the day. They may need a nap or go to bed a little bit earlier. But a lot of my patients are able to continue to perform their activities of daily living, including their job or taking care of children, if that's the case. Then the next set of side effects that we commonly see during the course of radiation therapy will have to deal with the skin. So the breast tissue is right below the skin surface. So the skin itself is getting the same dose of radiation that the breast tissue itself receives. And what that means is that the breast will have side effects. So we can see that the breast may get pink and it can get red for some patients. Rarely now do we see the same peeling and oozing that, sometimes people think about with radiation therapy for breast cancer. So it's usually pink red, and we may see some peeling. But like Dr. Guardiola mentioned, just like the hair grows back, your skin will heal. And to help decrease that intensity of a response, we do have skincare guidelines. So there has been some research that has shown that using specific creams helps decrease the risk of developing that breast reaction. So we provide all of our patients with detailed skincare guidelines in an effort to help decrease the side effects that they may experience during the course of therapy.
Yeah, and I think it's so important that people realize that a lot of the research that has been done over the past few years is in these medicines that assist and keep the patient's quality of life great. And that's why you have to disclose everything you take You know, I mean, almost everyone has gone through a cancer journey with a family member, and you know, watching how all those things play into each other, so crucial. Thank you so much, Dr. McDonald. After a mastectomy, some women choose to undergo breast reconstruction surgery. How soon after a mastectomy can this procedure be done?
So I think that depends. It depends on what the patient's goals are in terms of reconstruction. It depends on how they presented initially, how advanced their disease is. And so for patients who are undergoing mastectomy as the first step, if they don't have risk factors for complications of reconstruction, such as smoking, obesity, diabetes, previous surgery or radiation to the breast, then if they're an ideal candidate for reconstruction, then we try to get them to direct to implant. So breast surgeons often work with plastic surgeons simultaneously to perform the implant reconstruction after the mastectomy. Some patients are not ideal reconstructive candidates and may need to have tissue expanders placed, which are kind of like hard implants. It's just like a spacer. It's not an implant, but it's a little bit harder, and it gets exchanged for an implant later on. Patients who are having radiation after mastectomy, that may be a better option than radiating a nice, fresh implant. Some patients are opposed to having a foreign object. So they want to have what's called autologous reconstruction, where they use their own tissue to make a breast bone. So I think, the timing, a lot of it's kind of done simultaneously, but, it may be done in stages. So it may be a longer journey than just one and done.
Right. Yeah, so many options that we have right now. And that leads into quality of life issues. Dr. Guardiola, quality of life after treatment is something patients and their medical team they definitely consider. What factors are weighed when determining what treatment plan is optimal for the best quality of life? And correct me if I'm wrong, but more people are living with cancer than ever before.
So it's a good starting point to actually take up on what you just said last and dividing the goals of treatment, right? So for the vast majority of patients, we're likely to say that the goal of treatment is cure. And that goal will lead us to certainly, if you will use the word, ruin quality of life very temporarily, and for the time that the duration of the treatments that will secure that goal to cure will be at. So we ask the patients to actually see it as an investment, right? So I'm going to lose my hair transiently, I'm going to get nauseous, I'm going to get a little fatigued and tired, what have you. Won't be able to do normal activities for a few weeks or what have you. But we can almost promise everyone that the quality of life will return to normal once you're done and over with all the treatments that we're offering here as a multidisciplinary approach. Now, on the minority of patients that actually are living with the disease, right? So we cannot necessarily stop aiming at cure, but we're aiming at living with a condition in a chronic way, for which most of the treatments become an ongoing thing, similar to we're trying to come up with a disease that is almost resembles diabetes or hypertension, where we cannot necessarily tell you you're going to stop a medication at some point, or we're going to completely be done and over with it, but we're going to make you live the journey with the disease with the best quality of life possible. And that has led to a significant change in the treatment algorithms comparing the past to now. In the past, the more diseases someone has, or the more spread, the more aggressive we were, for lack of knowing, right? And now we came to realize that we don't necessarily have to be that aggressive in that scenario. We can stagger treatments in a more less aggressive way, less quality of life issues, and be more of a continuous event. And that has been, I would say, the biggest mindset change in the last 10, 15 years as far as how to approach patients that live with cancer, more so than the ones that were just going for the goal of cure. So certainly quality of life is an important matter, but it's important to understand the goals and matching them, and what are we asking the patients to sacrifice as far as quality of life. Yes.
Yeah. Dr. Contreras, tell us about the Cancer Support Center at the Miami Cancer Institute as we talk about this, because all of this is, you need specialized support to get through your journey, depending on your diagnosis, but just the whole shock of it and each stage that you will go through.
Absolutely. It's a really important part of care, because as we are all aware, cancer affects every aspect of your life, and not just your life, but your family members, right? So I think we are unique in that we offer a lot of resources for our patients. If there are a lot of society, they've under a lot of stress, we have amazing therapists that can work with our patients. We have psychiatrists that just specialize in cancer care. We have nutrition, we have diet, nutrition, we have exercise classes before the pandemic, but still they will return to really help these patients cope with a lot of the physical side effects that you get from cancer care. And we also have patient navigators. Patient navigators are such an important part of the treatment paradigm. They've been specifically shown to improve outcomes in patients with breast cancers. Patient navigators help patients navigate the healthcare systems, go between appointments, between surgery, medical oncology, radiation oncology, and they just help them keep everything in order. And lastly, we have support groups, because we know support is so important. And I think any of us on this call can talk till we're blue in the face, but it really makes a difference to see and get the perspective of someone that's gone through this disease and has survived or understands what to expect. So we really have a comprehensive support system for patients at MCI.
Yeah. Dr. Guardiola, do you want to add to that?
No, just in agreement with Dr. Contreras. The support, in the past, we honestly did not look at support services in a way other than just a pure benefit for the patient outside of anything else. Nowadays, there's science behind this. There is not only quality of life improvement, but there's overall survival improvement, which is a shocker to all of us, that a non-therapeutic intervention, if you will, of just supporting the patients for multiple angles actually improve survival. That has already been published. So for us, it's a no-brainer to have supportive services of all kinds, anywhere from nutrition, psychological support, acupuncture, and so on and so forth. And again, the important thing for us, and the luxury of working here at Baptist, is that we have under MCI everything under the same roof. So it's a one-stop point to actually get all of it accomplished, which I think is a benefit for the patients, no question.
Yeah, I mean, and those support services are so crucial. I mean, like I said, I've had family members go through this journey, and as the caregiver, a lot of times you need those services. And so it's so wonderful to know that all of that is being provided here. Dr. McDonald, what kind of advancements can you tell me that has made cancer surgery better or less invasive or just more tolerable for patients?
Yeah, I think the big thing now in breast cancer surgery, there's a lot going on actually, but one of them is something called oncoplastic reconstruction. So for patients who have moderately sized tumors, but really want to preserve their breast and don't want to have a mastectomy, we have the option of doing kind of a large lumpectomy with rearrangement of the breast tissue to kind of close that space so they don't have a deformity, because patients don't want to look at their breasts and always be reminded of what they've been through. So that's a really nice option now in surgery.
Yeah, no, it's South Florida, where it's warm most of the year. We all want to look good, right? Especially when you go through something like this, you're like, listen, I'm going to live my best life as long as I have it. Yes, right. So after treatment has ended, what does the average follow-up care plan look like, Dr. Guardiola?
So good question. There are some certainly subjectivity to that. Certain rules apply. So I will say, as a rule of thumb, and again, not that one size fits all, we tend to follow patients every 6 months, and that will include lab work, physical examination, and then depending on the type of surgery, continue with imaging of the breast if deemed necessary, particularly if there has been breast conservation. We have to obviously continue the process of screening for, God forbid, a new process altogether, besides just looking and making sure that there's no recurrences. And then there's the in-betweens, right? So that's where the patient comes into play, right? In between appointments, it's important to actually raise awareness that something is not right. We prefer false alarms than actually assuming that things are normal when they're not. And so it's an evolving and dynamic process that the patients learned as well. They get to learn their own new body, if you will, if there is a change in the way they feel or consequence after surgery, radiation, and or chemotherapy. They have to understand what is the new baseline and the norm, and more or less alert us of any problems, while we also check for objective findings. Short from that follow-up, and that follow-up is determined in years, depending on the subtype of breast cancer. So again, not one size fits all. Some of patients, most of the survivors are offered more than 5 years monitoring, particularly because most of them are on anti-hormonals, which is a very common medication to use for prevention. And then the biggest question and what is being debated are more specific secondary studies like full body images, something called tumor markers in the blood. Without getting into details on that, that has to be discussed further on each unique cases, because not necessarily everyone benefits from doing, let's say, a full body scan on a yearly basis to go on checking things, or tumor markers measured in blood, which are proteins in the blood. So I leave that more for like the discussion on a one-to-one end in between the physician and the patient.
So important. It's all individualized. And that's what all this research and care is showing you, that every person is different. Every person, and that's what's amazing about the specialized care. Dr. Contreras, should patients consider taking part in a clinical trial study? How do you feel about that?
I love clinical trials. Absolutely. I fully support it. You know, clinical trials are really the only way that we're going to advance care. So the reason that we have the great outcomes that we have, particularly in early stage breast cancer, is because women participated in studies. This is our opportunity to advance care. And one thing, you know, sometimes patients are scared to participate in clinical trials, but I will say that when someone is on a clinical study, they have really close follow-up. So they are being watched and cared for, not just by their physician team, but they have a research team that's helping them ensure that they have close follow-up, that they have the most updated imaging, if that's indicated. So I fully support it, because it's the only way we'll continue to advance care. And it really does provide patient with the added benefit of more support throughout their course of treatment.
Yeah, we have a question coming in from one of our viewers. What is the difference, Dr. Guardiola, between oral chemotherapy and chemo given by IV? Or Dr. Contreras, either of you can jump in and take this.
Yeah, so I can comment on that. So oral chemotherapy, so chemotherapy per se is a medication that, if you will, kill cancer cells, but it's not specific to some cancer cells itself. It just happened to be a killer of cancer cells, because our medications that work in fast dividing cells. Because arguably the reason behind the side effects is that it does affect fast dividing cells of our body. So for example, the hair loss has to do with that. So oral chemotherapies are just the same principle, medications that kill with no specific target, but they are available by mouth. So in other words, we can take it by mouth and being absorbed through our stomach into the bloodstream. We don't have many, as a matter of fact, and most of our chemotherapies are indeed given intravenously to go straight into the IV. I cannot say that one is better than another. There are different applications for them both, but I'll say that for oral chemotherapies, the role is very limited in prevention, except for a unique set of patients called triple-negative breast cancer, whereas the vast majority of patients that do need chemotherapy and are either hormone-positive breast cancer or triple-negatives or HER2-positive breast cancers, they do benefit from the IV form. So that's pretty much where the difference comes.
Thank you so much. I know I feel much smarter after this conversation now, for all your brilliance. As we wrap up today, any parting thoughts? I'm going to start with Dr. McDonald.
I think, being Breast Cancer Awareness Month, please go out and get your mammograms if you've been delaying it since COVID. That's what I would say.
Oh, she stole that line from you, Dr. Contreras, right? That's what you were going to say too,
well,
right?
She stole mine too, yeah.
Any parting thoughts, Dr. Contreras?
No, I fully support Dr. McDonald. Screening mammography is so important. It's improved survival for women. It allows us to identify cancers before they're big and require more and more intensive treatment. So please go out and get your screening mammography and encourage all of your friends and family members to do so with you.
Yeah. Dr. Guardiola?
Thank you for leaving me no room for comments. I think, yes, to add to it, one of the biggest, I'll say the biggest impact in survivorship of breast cancer has to do with mammograms. So I want to deliver that message because it is believed that we have advanced the field by treatment only, right? So we have gotten better with surgery, we have gotten better with radiation, and we have gotten better with chemotherapy. But make no mistakes, I think the difference in between the last 60 years outcomes in breast cancer nowadays, the bulk of it has to do with early detection. And the only way we can early detect this is through a screening mammogram, regardless of family history. No, I don't have family history of breast cancer. Doesn't matter. one in eight females are going to deal with breast cancer at some point in their life. That's a fact, whether you have a family history or not. So screening mammography is a widely worldwide accepted early screening technique. Everyone should get it after the age of 40, a more individualized age, starting and situation depending on uniqueness. So it's just emphasize what everyone said here. I think it's the best message for this month is that, no questions.
That's right. Thank you so much. Thank you so much to this brilliant panel. It's been an honor to moderate this. We appreciate your insight, the audience. We appreciate you too. Remember, viewers, you can always connect with us on our social media channels, Facebook, Instagram, Twitter, and LinkedIn. Do we not have a TikTok yet? Come on, Alexis. And check out our resource blog for the latest news at baptisthealth.net/news. You'll find a link there to all episodes of the Baptist Health Talk podcast as well. On behalf of everyone here at Baptist Health, my name is Neki Mohan. Thank you. It's been your honor. And we ask you to please stay safe and say yes to the COVID-19 vaccine.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Resource Live is brought to you by Baptist Health South Florida, healthcare that cares.